CLGB SWOG 80405 was designed in 2004. It represents a collaboration between the legacy CLGB, which is now called the Alliance for Clinical Trials in Oncology, and the Southwest Oncology Group. And I'm pleased to be here to present these results. This is the final design of the study I'll present today. A final design because this study evolved over the 10 years it was open because of changes in the field. Patients received who had metastatic colorectal cancer that was untreated in first line, whose tumors were KRAS wild type. So with molecular analysis, KRAS wild type defined in this study as codons 12 and 13. Patients were stratified based on the chemotherapy that was given, as well as whether they'd received prior adjuvant therapy. The chemotherapy, FOLFIRI or FOLFOX, each are standards, and those were given at the discretion of the physician. So as patients enrolled on the study, the decision was made by the physician and patient which chemotherapy they would use. The randomization was between chemotherapy and cetuximab, an anti-epidermal growth factor receptor antibody, and bevacizumab, chemotherapy plus bevacizumab, an anti-vascular endothelial growth factor antibody. These two drugs in 2004 were both newly approved for patients with metastatic colorectal cancer with very different toxicity profiles. Cetuximab renowned for the acne rash, and bevacizumab with some consequences regarding clotting and bleeding. These two drugs were new at the time, and this was the question asking which is the optimal first-line treatment for these patients. I'll report on 1,140 patients, and the primary endpoint was overall survival. These are the results that I'll present. This is the overall survival data. In blue, chemotherapy plus cetuximab, patients receiving that regimen had a median overall survival of 29.9 months. In yellow, patients receiving chemotherapy and bevacizumab had a median overall survival of 29.0 months. The p-value here is 0.34, the hazard ratio of 0.925. This study, therefore, does not show a meaningful difference between these two arms. Our assumption when we started the study was that we were looking to see if one arm was better than the other. In fact, we had no knowledge which one would have been better. This was essentially looking for a difference in the treatment arms. And what we see here is, at least within the statistical boundaries we have, there was no statistical difference. Progression-free survival, which is the decision to move patients off of the first therapy because the cancer has progressed, was also not clinically meaningfully different nor statistically different. In yellow, the chemotherapy bevacizumab group had a 10.8-month progression-free survival, which numerically is slightly greater than the blue curve, which is chemotherapy plus cetuximab, but again, not statistically significant. This is as determined by the investigators. So these two distinctly different biological therapies in combination with chemotherapy did not impart a different outcome for the patients receiving either one. What I'll present today is limited by the fact that there's a lot of data still pending and that we're still working on. This data was just released 2 months ago by the Data Safety Monitoring Board. So in fact, there is information gaps that we will fill in as we go along over the next 6 months to a year. Duration of therapy, dose intensity, classic marker response rate, which is of interest. Many patients underwent surgery. In fact, over 100 patients underwent surgery and for at some period of time, if not even still today, remain free of cancer. About 10% of patients achieved a complete response, which is to say they had no evidence of cancer. We have other details that we're still waiting for as well, sequence and crossover to other biologics. So there's a lot. The data I'll present is limited in terms of our full base of knowledge, but again, the overall survival is a solid endpoint. The conclusion really from this is that there is no difference between these two therapies as the starting point for patients. Patients, of course, came off of the designated treatment and might have gone on and did go on. 88% of patients went on to subsequent different treatments, and at the end of the day, the survival was the same. For patients, what this tells us is that either FOLFIRI or FOLFOX with either bevacizumab or cetuximab are are perfectly reasonable options for first-line therapy for this population of patients. Essentially, patients have four choices, and doctors have four choices of which therapy they might initiate for patients. And patients can make this decision based on preference for toxicities, on other issues, because these appear to be equivalent in terms of long-term outcome. The other meaningful difference here is that the overall survival exceeding 29 months in both arms really establishes a new benchmark for the treatment of patients with colorectal cancer. This was accomplished across a broad clinical trials network through the United States and Canada, and suggests that the results apply in a variety of practice settings, not just in academic centers. We have detailed analyses pending of some of these subsets with molecular features to be analyzed that we hope will explain the outcomes for these patients. To put this in perspective, what I've done here is, in black, this is a graph, a survival curve from a meta-analysis done in 1992 called the Colorectal Cancer Meta-Analysis, published in the Journal of Clinical Oncology. And this curve here represents the median overall survival of patients in 1992 who had been treated on clinical research trials through the 1980s. And the median overall survival for this patient population was 8 months. Superimposed is the actual data from our study that I'll present today, CALGB-SWOG 80405, graphically demonstrating, now again, acknowledging there are different populations, things have evolved in other ways, but to graphically demonstrate the difference in survival for patients today compared to 20 years ago. While this is not a patient-for-patient identical subsets, this gives you a sense of the breadth of the difference we've imparted. This is incremental over many years, but again, in this study, every patient, the median survival of 2.5 years represents a new standard for which we can from now work. Now, the take-home message, again, is that this is for patients with KRAS wild-type metastatic colorectal cancer. They have choices. The first-line therapy can reflect their preference for toxicities or other issues, and about 10% of patients in our study are living beyond 5 years. In fact, this is another new benchmark. These are patients with advanced metastatic colorectal cancer, 10% of whom live that long. This, I think, consistent with Dr. Huddis's comments to initiate the session today, this represents the value of publicly funded clinical research. This was funded largely throughout the U.S. intergroup and Canada. This is a study that clarifies the standard of care, that answers a question that industry might not ask. Companies who have bevacizumab or cetuximab might not be interested in asking this question. In fact, this is the role I think we play in the cooperative groups. This is incredibly important to practicing oncologists who face this question every day. These drugs are readily accessible across the U.S. and Canada, and in fact, around the world. This study took 10 years. There were 14 amendments, 11 interim analyses, so this is a work of many, many people, and we took as long as it was necessary to get the answer. And upcoming is a broad range of correlative research. We will do complete molecular analyses of we have 44,000 biospecimens, and we will do detailed analyses, and we hope that this can inform future studies in colorectal cancer. So what I present today is really the tip of the iceberg in terms of what we stand to learn from this study.